Hello, everyone. I'm Maria Theodoulou. I am the program director of the Breast Medicine Oncology Division at New York Oncology Hematology up in Albany, New York. And I am thrilled that we have Dr. Jeanne Carter with us today. Um, this is going to be one of a series of chapters that are educational chapters for patients, for their families, for providers, speaking about a specific topic with a thought leader that's an expert in that specific topic. We wouldn't be able to do this without the incredible generosity and grant support of Stacy and Richard Rosenthal, who have been really wonderful in allowing us to have these programs year after year, live programs. And now these programs will be available to patients on the YouTube NYOH arena. And I'm hoping that they're going to all flow through about February of this coming year, 2025. Well, let me just say that I feel privileged and excited about having Dr. Jeanne Carter, who is an attending psychologist at Memorial Sloan Kettering Cancer Center. She is a clinical psychologist and a certified sexual health therapist who not only provides incredible help, education, and interventions to so many of our patients who have their sexuality and their sexual function abruptly interrupted because of therapies or their diagnosis, or just as a natural evolution of where they are in their aging. But she's an educator and passionate and compassionate, and she serves as the head of the Female Sexual Medicine and Women's Health Program and Care for Patients at Memorial Sloan Kettering's Barbara White Fishman Women's Health Center. And I remember taking care of Barbara White Fishman. So what a wonderful honor it is to have her grant, and you're taking it forward in such an incredible way. Dr. Carter is also a member of the attending staff on the GYN service in the Department of Surgery and the Department of Psychiatry. Jeanne, welcome.
Well, it's an honor to be here, Maria. This is such an
Oh,
important
I'm
topic.
thrilled. I'm thrilled to be with you, whether it's live or on Zoom or in any fashion. And I know patients are going to love this program. The issue that we have is that sexual health um, is not always addressed in
True.
discussions with our female cancer patients, and actually even with our male cancer patients. There's either no time, or we as providers don't think about it, or patients are just too shy or not comfortable having those discussions. How do you approach patients? How do you approach providers in educating them on how to approach this area of really major concern?
I think that's such a great question. I think you're right. There are so many individuals that have a different comfort level this, whether it's patient or provider. But I do think that women's health is kind of a good entree to that because I think when women go through a cancer experience, they want to be well and have quality of life and really move beyond this in a positive way. So a lot of the focus sometimes we have with patients as well as educating our colleagues is really to focus on women's health. Because if you do that, it enables you not only to get the individual who may not be in a relationship, who may want a relationship in the future, or who's really afraid of going for her follow-ups because she's having painful exams. So when we do a broader heading, it really enables us to almost detoxify it, and then it allows us then to ease into those really important discussions about how are you feeling about your body? Are you feeling connected to your body? Are you having any concerns individually or about sharing that with a partner? So I think it's a great segue to start the conversation and then go deeper. I think patients and providers need information. I think the field in general is getting better about addressing menopausal symptoms, but menopausal symptoms in the cancer setting is not the same. And I think women need more love and more TLC and more support and more conversations. And it's hard sometimes for patients to initiate that discussion. Sometimes it's also hard for providers. So we're trying to come up with creative ways of getting that information out there, whether it's a lovely video educational series like this, or a pamphlet in a clinic setting, or screening questions that can be easily used in the clinic to help address some of these concerns. So I think there's so much improvement. I've been doing this for 2 decades, and I'm excited to see where we're going to go.
I love that this is a broad topic that we not only bring to the breast cancer arena, but to patients who have had lymphoma, males who have
Mhm.
had prostate cancer. But I have to say that there's a tug at my heart for women who are diagnosed with breast cancer, because
Yes.
no matter how perfect their outcome is surgically, no
Mhm.
matter how skin sparing the surgery may be, the lumpectomy that you would never really be able to detect if you didn't know, there's always a reminder every morning when they
Mhm.
take a shower and they look at themselves that this was a diagnosis that they had to carry. And I say the
Yeah.
word had, HAD, for so many women who have gone through the experience, whether
Mhm.
it's a year ago or 5 years ago or 10 years ago. And I find that my patients in my breast cancer clinic rarely volunteer
Mhm.
information about their sexual health. I find that some of my younger patients will,
Mhm.
Dr. T, I am not having a good time since I stopped chemotherapy. Dr. T, I am not having a good time since I started endocrine therapy. But more than not, it's because we asked the question,
Mhm.
as you described. And it's interesting to me that there is no age barrier. It could be women in their 20s and 30s. I have women in their 70s and 80s
Mhm.
that are concerned about their sexual health. And that doesn't necessarily mean intercourse.
Mhm.
And can you speak to that? Because we always have the umbrella of sexual health with the implication that we're talking about penetration. It's not just penetration, although we will talk
Right.
about that today.
Absolutely. I think, and it's such a great point. I think, you know, my goal in working with women when they have an experience like this is really to connect them to themselves and to their own sensuality.
Mhm.
And within that arena, sexuality emerges. And sexuality can be external touch, stimulation. It doesn't always have to be some sort of vaginal penetration. And again, people have different preferences, different partners, different abilities. As we age, sometimes having something in the vagina can be more challenging. So I think it's teaching women how to age gracefully over time, but also really acknowledging that, meaningful, intimate touch can be so many different experiences, and again, it's helping people to be able to do that successfully with comfort. We talk a lot
You
about the vagina in
know,
sexuality, but there's also the vulva.
you know,
All
in
the tissues outside, that's where the clitoris is, and women can be uncomfortable with daily activities or working out or bathing. And definitely that can create difficulties. And I also have a special place in my heart for the breast as well as the GYN patients, because the sites of their cancers are so specific to
Mhm.
how we feel about our sexuality. And definitely the treatments that need to happen to make them well have significant ramifications. So it's our job to make sure that we're giving information and talking to them and giving them ways to heal their body. And a lot of that can be done with non-hormonal options. Of course, low dose estrogens in the appropriate patient are an excellent resource. And sometimes that's a better idea for our heme patients or our colorectal and anal cancer patients, and their comfort level of that is more. But we've had many challenges with our breast and GYN patients because of these hormone sensitive tumors. But we've studied things on clinical trials, and things can be effective, but we have to get the information to our women for sure.
What's interesting, I just got back from the San Antonio Breast Cancer Symposium. They actually had a wonderful session on sexual health, and I was so pleased to see that time dedicated.
Mhm.
And I learned the difference between the Rosemary Basin model of female sexual health,
Hmm.
health versus Masters and Johnson. And I thought that
Hmm.
was so interesting, talking about female responsiveness
Yes,
to stimuli and how it functions within us versus just spontaneous, nonlinear
exactly, exactly.
applications. Could you speak to that a little bit?
Oh, yes. I always say women are wonderfully complicated. Because I think and this is not 100%, but for the majority of women who identify as being female, there is an interplay between both physical and emotional and cognitive factors that are wonderful and that can help us as well as sometimes hinder us. So I think Rosemary Basson did a great job of pulling in all those feedback loops to try to help women to understand that it isn't linear and it's not stages and that there can be overlap. And I think a lot of times we see that, and even the DSM has changed the diagnostic criteria, is that arousal and desire feed off of each other. So if you are having a good arousal response, which can be challenging as we age because of circulation and tissue quality, and you're putting energy into something and it's not as satisfying, it can then hinder your interest in doing that, which is literally desire. So I think we need to teach the world that desire can be spontaneous, but it also can be reactive. So I think if we help women connect with themselves and feel sensual and make sure that we're managing their symptoms, because Maria, you and I both know a lot of these medications can have a lot of different side effects. So if women are not sleeping, that's a huge problem because then they don't have energy. If they're having hot flashes, thinking about cuddling with another human can feel overwhelming if you're feeling that you're too hot. And making sure that if there's any mood lability or anxiety, that we have that in a manageable range so that people can connect and enjoy. Performance anxiety is something that happens a lot for both men and women when they're worried that they won't be able to perform in a way that they would like, when they're worried about the expectations of their partner, which can undermine their confidence. So I think in the cancer arena, our job is to manage symptoms, to help women connect with their body, and then they would then have the confidence to share it. And in that experience, it can have so many different realms. It could be self-stimulation, it could be external stimulation, it could be oral stimulation, it could be penetrative sexuality or not. I mean, there's a whole wonderful array of ways to enjoy your body and share it with another human being. But if people don't feel confident or they don't feel connected, it's a huge issue. So I think we really do need to pay attention. And those are the cognitive factors that can undermine people's success. I have a lot of people that tell me they go on vacation and everything works so much better. It's not being on vacation, but it might be being more relaxed, being able to be more attentive or feeling more appreciative of time alone with your partner. Maybe it's because it's a new space. It feels spontaneous. You're relaxed more. Like these are the things that we need to help women in general capitalize on as they're aging. But in the cancer arena, it's so important because there are other things that creep in, as you said, like reminders of scars or changes of sensation or worrying about, if their partner's desiring them because their body may look or feel different. So it's
And really
really
addressing with patients whether they had a healthy sexual desire and libido before their diagnosis.
right.
If they
Such an
had a
excellent point.
healthy relationship prior or a healthy relationship even with their own body
Yes.
prior to their cancer diagnosis, I think reassuring them that we can get them back there after the trauma of hearing the diagnosis, going through whatever needed to be done in order to render them disease free. Certainly, the medications we use are often like a psychological battering ram, and then when we are done as providers, we leave those patients in a room with lots of questions and a lot of emptiness.
Mhm.
And if they did not have a healthy relationship either with a partner or themselves, perhaps then to reroute our discussions as to how to help them get to that place. They might have had needs that were not addressed prior to their diagnosis.
It's an excellent point. I would definitely say that you bring your life experience when you're dealing with cancer to the table, and that's also going to follow you into recovery and survivorship. But if someone didn't have good communication or didn't have satisfying sexual activity before, a lot of times going through an experience like this makes individuals want it more, like to have a shift in their priorities. So there's a growth opportunity here for sure. I think women need information, they need preparation, they need education. I think if we prepare our patients that certain changes could happen, and let them know that we have resources to help them as their body's trying to find balance, I think that can be uh, a very more humane and kind way to help women ease into changes that they didn't ask for, that they have to compromise about, and maybe even grieve. But I think we can get there. I mean, my expression to my ladies is things are going to be different, but different doesn't have to mean bad.
Mhm.
So it's an opportunity to understand. But I think it's hard when individuals go through something like this and they're so focused on, I just want to be here, I just want to live, let me get through the treatment. And then the dust settles, and now they're either done with treatment or on their maintenance therapy, and they try to connect with their body, and their body feels completely different, and they weren't aware. So that's where we have to educate women, because I think we adapt and we adjust better when we know that things could possibly happen. And we don't know where everyone's going to fall. So we can't say, oh, if you do this, this is exactly what your body's going to feel like. But we could say, some people might feel a little dryness, or some people might feel a little pain, or it might be hard when you notice that your body's not functioning the same, or you now have lack of sensation in an area that was very meaningful for you. But how can we help you with that? How can we help
Yeah.
you discover other parts of your body?
So
How can we?
often patients come into me and they're focused on their breast exam or their chest wall exam.
Mhm.
And we pay so much attention to making sure they're up to date with their breast imaging and their
Mhm.
follow-ups. And we forget sometimes what's going on below the waist. And for so
Yes,
many patients, what's going on above the neck, because our
absolutely.
psyche and our way of thinking about things and approaching things weighs so heavily. And I have to say that the one thing that you did say a few minutes ago was lack of sleep and hot
Yes.
flashes. You know, you don't feel sexual when you're breaking out in a sweat and you have to change your nightgown and you've lost sleep during the night. And I think that's where we as providers really have to address all of these issues, maybe change the time of day patients are taking their medications, talking to them about how to decrease hot flashes with lifestyle changes, and not unhealthy changes, often healthy changes, decreasing alcohol, making sure they're staying away from caffeinated products, things that can just incite those hot flashes, whether you've had a diagnosis of cancer or not. But I will say you have come a long way in helping us take care of patients. And, Jeanne, you and I go back decades to when I was at Memorial Sloan Kettering.
Mhm.
And uh, one of the things that I always found so important was that it's not just about our vagina or our vulva, or it's also about our urethra and
Mhm.
the linings that are so similar throughout those areas that oftentimes do get thin with estrogen deprivation.
Mhm.
And um, asking about those issues. Do you have also discomfort when you're urinating?
Mhm.
Because that may lead to a discussion about overall sexual health. And I'm going to give that platform to you right now.
I think that's such an important point, Maria. I mean, it is the whole genital ureteral area that gets impacted by lack of estrogen. And usually that happens gradually for women over time. In the cancer arena, it's more acute and compressed, so their symptoms can be quite dramatic. We have a lot of women that have chronic UTIs, or they have discomfort with urination or wiping. And I think you have to moisturize both internally and externally to help those symptoms. I also worry about all my ladies who are having incontinence issues and are wearing panty liners and pads,
Mhm.
because although those are very important to give you security when you're leaving your home or are traveling a great distance, their job is to remove wetness and moisture. So we literally have women drying their vulvas with techniques trying to help them stay dry. So when you improve the tissue quality by using hydrating moisturizers, you also can use barrier creams if you have incontinence issues. And this is such an important quality of life issue. And we learned this really from our colorectal and anal cancer patients who have extensive pelvic radiation and have a lot of bowel and bladder issues. And the whole genital area just feels irritated and sensitive, and it's painful for daily activities. Just using things like a barrier cream and moisturizing can be a huge quality of life piece. Now, that's not only to say that these are the areas that are intimately touched with sexuality. So if you're having, tissues in that area that feel like they're on fire every time you go to the bathroom, sexual activity is not going to feel very attractive. So we always try to look at the whole gestalt of this. I mean, I'm always asking about energy level and sleeping and symptoms and bowel and bladder function, because these are the things that can help us be successful or can hinder our success. I think a lot of times in the field of sexual medicine, it's either people are talking about estrogen and the vagina or medications to help with desire and isolation. And I'm always like, you have to look at how they all feed together, which is, again, what Rosemary Basson did. So we want to make sure that we can physically get women in the best place to be able to share their body, enjoy their body, feel confident about their body. So we do need to talk about circulation and tissue quality, which can be done with low dose estrogens if appropriate, or non-hormonal hydrating moisturizers. We found the oil-based moisturizers don't seem to be as efficient as healing the tissues to help with elasticity. And the vagina naturally should move like a rubber band, but if the tissues don't have the capability to move, you're going to have pain, and you also can tear tissue if they're very thin and fragile. We also want to make sure if women are having incontinence issues, we always focus a lot on the pelvic floor muscles, which are great to help strengthen and support that. But every time you use these muscles, Maria, blood flow has to go to them. So it works the same pathway for your arousal response, which is
Mhm.
fabulous. In addition, these are the muscles that when you contribute to pain, everybody tenses. I love doing that because people are like, yes, that's me. If I can
I
teach you
just
how
read
to,
a paper where pelvic floor exercises were actually more successful than vaginal moisturizers, which were more successful than olive oil.
yes,
And
yes.
and I wonder if we could talk a little bit about the difference between a lubricant and a moisturizer. I find that often patients tell me, well, they're using something over the counter
Mm-hmm.
and they use it only when they want intimacy, either with a partner or themselves.
Mm-hmm.
And then I say, oh, wait, you don't put moisturizer on only when you go to a fancy dress ball.
Right.
So let's talk about lubricants and moisturizers.
Such a important distinction. So by definition, a lubricant is usually something that's there to help enhance your lubrication. So these can be water-based, oil-based, silicone-based. They're there to minimize friction and really decrease discomfort with sexual activity or touch. Our body biologically should be doing that. When we get aroused and we get blood flow and it goes to the lower genital area, the vagina usually will elongate and secrete. But as we age, our tissue quality may not be able to secrete at the same frequency or caliber or quantity as when we were 20 versus being 30 versus 40 or 50. So I think lubricants are there to just help us enjoy sexual touch and activity, but they are a band-aid. The moisturizers, and estrogen is a natural moisturizer. So as we have less estrogen over time, our tissues will have less moisture. So either you can replace it with low dose vaginal estrogens, which a lot of women do in the postmenopausal setting. But if you have concerns about that, or you feel it's a contraindication, or you're nervous about that, then moisturizers are a great option. And their goal is not for sexual activity. You would administer a moisturizer in the vagina, as well as apply it at the vaginal opening on all the folds outside, so that you have good vulvovaginal health and tissue quality in both places, which not only is important for sexuality, but also is important for just daily activities and comfort in your own body.
Sure.
We have learned over time that the hydrating moisturizers seem to be more efficient in our cancer populations because of the acuity of the dryness that they experience. So these would be things that have hyaluronic acid in them, and there's a variety of products that are now available over the counter. And Replens, which is a polycarbonyl, we have 3 decades of research and experience in cancer populations, is also another excellent product. So I think in general, when you're trying to understand the distinction, if it's advising you to use it for sexual activity, then it probably is more of a lubricant. But if they're really having you just use it in the vagina or on the external tissues to just leave there to improve tissue quality and comfort, then that's more in the realm of a moisturizer. We usually have women moisturize at bedtime, so gravity works with them, not against them, because anything you place in the vagina and you stand up will start to come back out. So I think bedtime is the ideal time to do this. And I have a lot of women say to me, well, how do I do that if I want to be intimate? I'm like, well, be intimate first, enjoy yourself, use your lubricant, go to the bathroom. And then right before you go to bed, put it on the external tissues and in the vagina so it has many hours for ideal absorption. And there are gel forms of moisturizers, suppository forms of moisturizers. I have a lot of women that use the same moisturizer in their vagina on the vulvar tissues because we studied that on clinical trial in our breast cancer patients on aromatase inhibitors and our endometrial cancer patients after having their uterus, ovaries removed and a little bit of radiation. And it was shown to be highly effective both in the vagina and on the vulvar tissues. But the key is women had to use it at a higher frequency than what the box recommends. It recommends 1 to 2 times per week if you were going through a natural menopausal decline. We found women in the cancer arena needed to moisturize at least 3 to 5 times per week, using at least a full to a half applicator on the external tissues and a full applicator in the vagina. So I think that's where we get a lot of women failing with these strategies is because they're using it for the general population going through menopause recommendations. And truly, women in the cancer arena do need extra support, extra administration of these products.
Can you speak to our audience about the difference between the vulva and the vagina, as well as what hyaluronic acid means? I know you published a single-arm prospective trial in postmenopausal women regarding the effectiveness of non-hormonal vaginal moisturizers with hyaluronic acid, but let's define some of those terms for our audience.
Absolutely. So hyaluronic acid exists naturally in the body, and the cosmetic dermatology field has known about hyaluronic acid for quite some time because it's in all the facial creams and preparations. And we had been reading about it in the literature many years ago in Europe, and it became one product became FDA approved in the United States in 20, I believe 11, and we studied it in 2012. And that's where we found that these products could be highly effective being used in the vagina, meaning you're filling up something and putting it into the vagina so it has time to adhere and absorb into the walls. Usually you're placing that very far back in the vaginal canal. And that's important because it will start to make its way towards the opening, but it may not hit the opening. The opening itself, we call the introitus, the soft tissue around it, we call the vestibule. And we have our folds outside, which we call labia majora and labia minora. And all of that encompasses the vulva. So the tissues can be impacted by things going in or being moved and touched. So we want to make sure that we're moisturizing all of that, as well as the nub of the clitoris, which has extensions into the labia. We want all of that area to feel good and to move and to be able to have good sensation and not have discomfort, which is why we moisturize in both places.
We hear now about different medications that some of them have been approved here in the United States, some not. But two that have been approved, and I hope I'm pronouncing them correctly, is fabanserin.
Yep, Addie or flubanserin.
Adia, yes.
Yep.
Yeah, and a lot of them say that it's the equivalent of it's the pink pill, which is the equivalent of the medication that men use to maintain an arousal state, but that's not true.
No,
It's
I
not true
think
at all.
no.
And if you could tell us a little bit about ADI, and who would be a candidate for it, and what we know about it.
Right. So the blue pill you're talking about for men really is to promote more blood flow, right?
Mhm.
And that is important for arousal, but that's not really going to help with interest per se if there's other difficulties. And they actually studied sildenafil in women, and it didn't work because it had more blood flow, but women didn't feel mentally turned on. So we have to make sure that we're not only really helping with the physical aspects, but also addressing the cognitive and emotional simultaneously. So,
Because that is the common complaint. I don't feel
yeah,
like it, quote
yeah,
unquote. I don't feel
exactly.
like it. My libido's gone.
But if we give someone to a medication to enhance their desire and they're like, oh, yes, my partner looks lovely, I want to try this, and then all of a sudden everything hurts, it's going to negate that benefit. So I've always found that you have to, with any medication, you have to really promote tissue quality and comfort so that a woman can be in her body and connect with that and feel pleasure. And I do think Addyi or fulbanserin is a very intriguing medication because it works on the dopamine and serotonin pathway, which is where all our drives are. So when women say, "Oh, I have no hormones, I have no sexuality," I'm like, "Well, all the medications to try to help you with desire are non-hormonal. So let's talk about your brain. Let's get you connected. Let's get you involved. Let's have you trying stuff." We did study it in a feasibility study, and it seems to be promising. So I love that the sexual medicine field is trying to help women with this issue. But right now, it's FDA approved for premenopausal women without
Right.
a medical condition. So it makes it challenging
Mhm.
for our patients. There was a study that looked at Wellbutrin or bupropion, which we
Mhm.
know can negate sexual side effects associated with serotonin reuptake inhibitors or antidepressants, which has been proven in clinical trials. In this particular study, they didn't pay attention to the vulvovaginal health issues. They let women be able to use any moisturizer they wanted, but they didn't control for it or advocate for it.
Sure.
So that study failed. And when we went
Mhm.
back and we looked at that sample, actually, I think it was something like 94% were all having dryness and lubrication issues. So, we'll never know if we had paid attention to that more, if it could have changed things. So I think that we must make sure that women have good tissue quality and good circulation. And when we do that, and we either by trying to enhance their connection to self, there was a lovely study done by Laurie Brado, a group from Canada, where they taught women about mindfulness and how to be more mindfully connected to their body. And when they did that and then had them approach it with that mentality to their sexuality, they found that it actually enhanced their arousal when they showed them erotica. And they actually put a probe in the vagina and it didn't increase blood flow, but women felt more mentally turned on. So I always said, like, we need to do sildenafil with the mindfulness intervention, and maybe we'll have like, success in both. But what it teaches us is that the complexity of women, which is extraordinary and wonderful and makes us wonderful because women are natural multitaskers. That's how everyone survives. But unfortunately, sometimes it's hard for women to quiet that noise and connect with her body. So the more that we can teach women to be in their body and connected with that and observing that, they will be more likely to feel pleasure and to feel arousal and to feel interest and enjoyment if we're not having the distractions of dryness and pain. So I think we have to go with the integration of this if we're going to successfully. It's not just about moisturizers and it's not just about, desire medications. It's really about trying to make sure that we're getting both pieces to simultaneously integrate and have that be a positive thing because we know how they don't work. If you're nervous or you're worried about penetration hurting or worried about not being able to reach an orgasm and disappointing your partner, or you're frustrated because you're self-stimulating and you're monitoring it and you're just not able to get over that hump because you're having a conversation in your head, those are all the things that will work against you. But if
Mhm.
we can quiet that chatter and have you observe the pleasurable sensations and connect with your body, but make sure that it is working with blood flow and working with good tissue quality, we can enhance that. And when you can do that individually, it's not as scary about sharing that with another person. There's no place you're more vulnerable than opening your body to another human being. So if you go into that confident, things are going to work better than feeling insecure about that or not feeling confident or worrying And that's a conversation that you're having in the setting of intimacy instead of connecting with your body and enjoying it and enjoying the sensations. Does that make
And
sense?
not to discount the issue if there is pain at the vestibule or if
Mm-hmm.
there's pain with thrusting,
Mm-hmm.
that an exam is critical.
Oh,
You
yes.
we shouldn't just toss it off to, oh, it's my anti-estrogen therapy, or it's
Yeah.
because I had chemotherapy a year ago. Having a relationship with someone that you trust that will do a thorough gynecological exam to make sure
Mm-hmm.
that there isn't something else that might be causing these issues.
That's such an important point. I don't think it's isolation. It's not just in the vagina and it's not just in your head. It's the loop of the integration of those. And if you're using something like a low dose vaginal estrogen or using a non-hormonal moisturizer and using lubricants and you keep having pain, like this is something that really does need a thorough exam. And sometimes people can have pelvic floor dysfunction where their muscles are just not working in uniformity. And pelvic floor physical therapy is a wonderful resource to really
Sure.
help women with that for sure. I definitely think nothing should be done in isolation. I think there's always got to be this wonderful blend of again, with everything, when you come in to see your doctor, it's about, oh, am I doing well in my cancer experience? And how is my life and survivorship beyond that? And then it's like if you're having difficulties in the realm of sexuality or comfort with an exam, like are you using these strategies to manage these symptoms and how are you feeling about those? There's always this dance that should be happening to understand the gestalt of the problem, not things in isolation. And I think that's where sexuality works the best. And I think that's why you love the Rosemary Besson model because it really does integrate those. It reminds
Right,
us it's
right,
not just one thing, it's the combination of all of it.
right. And I'd like to be able to touch on two things before we wrap up. One is topical lidocaine.
Hmm.
Um, there's a lot in the press right now. It was discussed at the symposium. Women ask about it. It's been published. Can we talk a little bit about lidocaine, diluted
Oh,
lidocaine?
absolutely. You're right. There was a study which really found it helpful for
Mhm,
dyspareunia, what we call, penetration into the vagina.
mhm,
But what I would say first is I would want to make sure that those tissues are
mhm.
have good quality and elasticity and movement because obviously a pain sensation is an adaptive response to warn us. So I wouldn't want people to just be using the lidocaine and
What an
tearing
excellent point.
and
Great.
tearing, right?
Mhm.
So I would advocate strongly for women to be moisturizing those areas and improving them. But in that setting, if you're moisturizing and you're doing that and you're still having pain, it is a wonderful resource. And I have had some women who have been diligent in their moisturizing, as well as using dilators and trying to relax the pelvic floor, which are other wonderful strategies to help women when they're having issues of pain, and they just needed something a little bit more to be able to work that area because the pelvic floor tension was so great. And lidocaine was a great resource. You also have to wait a little bit so you don't numb your partner, but definitely it can be a wonderful resource. But I would want to make sure the tissue quality is optimal before you did that so that you're not having women getting fissures or tears.
And that's where that exam becomes so critical,
Oh,
which allows
yes.
us to open
Mhm.
up the different avenues to discuss these issues. Um, I'd like to just ask a little bit about something that I actually asked you for a lot when I was at Memorial Sloan Kettering for patients, which are vaginal dilators, which we really don't hear about that much anymore, and they aren't prescribed in the community very much. Could you speak to that? Is that out of fashion
Oh
or?
no, absolutely not. We use dilators all
I'm
the
glad
time.
to
I'm
hear
giving
that.
I'm giving them out all the time, Maria.
Yay.
What I would tell you is dilators are just cylinder objects that gradually go up in size. They do come in all different shapes and sizes, and you can buy them over the counter. I think over the years, my preference would be for a woman to use a dilator that's more firm. And the
Mhm.
reason for that is you use the dilator to gently work the tissues in the vaginal canal to help restore elasticity. If there's any tight tissue that is formed because of different variety of treatments. I mean, ideally, these were usually given out to women who had radiation, but any woman that has pain, this is a great confidence building strategy because it allows you to have realistic expectations. You know, if you're using a dilator that's very, very small and you're hoping to have the benefit of intimacy with a male partner or to use a vibrator or another sexual toy, they're usually much larger in diameter. So you would want to be able to see that something could fit comfortably into the vagina and have that confidence before you tried to enjoy your body in that way. The soft ones tend to move more outside, so nothing moves inside. That's my preference for that. But I definitely think dilators are also really helpful to help women understand their pelvic floor muscles and to learn how to relax them because you're getting so much feedback. It also enables women to understand if they're not moisturizing enough because they're going to feel it with the dilators. So we use dilators all the time, all women, all types of cancer. The only criteria is that when they're feeling like they're not having as much elasticity or they're having discomfort or they're nervous. I have a lot of women sometimes go for surgeries and they're worried about what it's going to feel like in there. Great resource to understand that outside of the bedroom so that when you go to share your body, you're more relaxed. And if you're more relaxed, your pelvic floor muscles will be more relaxed. And that really is a huge source of pain. So dilators have not gone out of style. There's so many different ones now. If you Google them, you can get them online, but they're a wonderful, wonderful resource.
You know, the mortality of breast cancer has been decreasing over the years, and we always look to our improved surgical techniques, our imaging techniques, our imaging systemic therapies. I say that it's because it's come out of the closet and women talk about the issue of breast health. And I think resurfacing and reimagining and bringing our sexuality back to where it was, age has nothing to do with it,
Mhm.
is so important because now we're bringing it out of the closet and we have to talk about it and educate and question and not be shy about something that's so important to us in our life's journey.
Agreed.
Jeanne,
I think we are wonderful, sensual beings,
mhm.
regardless of what our body goes through, and no one can take that away from us.
I can't thank you enough for really doing this with me this afternoon. I think many women are going to benefit from it as well as men listening to it. I love you. I adore you. You are going to be the co-recipient of the Advocacy Award at the 7th Annual Breast Cancer Symposium next October. Nobody deserves it better. And I'm going to close right now. And everyone, look forward to different chapters about what we need to know about our own health on various levels with wonderful thought leaders from around the country. And I can't thank enough the NYOH Foundation and the supporters of the foundation that have made this possible. Jeanne, thank you and love you.
My absolute pleasure. My absolute pleasure. Thank you for wanting this topic addressed in your series. So appreciative.